High-risk pregnancy. Dr. Ravi Kumar. Introduction. Many complications can occur during pregnancy and affect health of mother and fetus as well as outcomes. Hemorrhage is the first 10 causes of maternal mortality and morbidity, affect about 32% of all maternal death. Abortion represents 0.5% of all maternal death. Many women do not understand the bleeding is abnormal and dangerous signs and come late to healthcare facilities. High-risk condition. Bleeding in early pregnancy. Bleeding in late pregnancy, antepartum hemorrhage. Pregnancy-induced hypertension. Diabetes mellitus. 1. Bleeding in early pregnancy, before 20 weeks gestation, causes abortion. Vesicular mole. Ectopic pregnancy. Local lesions, cervical polyps, cervical abortion. It is the termination of pregnancy before 24 weeks. Odds of conception weighing below 500 grams. The termination is either spontaneous or induced, before the fetus develops sufficiently to survive. Incidence. Spontaneous abortion occurs in 10 to 15% of pregnancy, 80% of them occur in the first trimester. Causes. 50% to 80% of abortions in the first 12 weeks of pregnancy result from chromosomal anomalies. Fetal chromosomal anomalies. Diseases of the fertilized ovum. Hypoxia. Maternal infections, for example influenza, malaria, syphilis, HIV. Disease such as chronic nephritis, TB. Drug intake during Rh and ABO incompatibility. Incompetent cervix. Uterine malformation. Acquired uterine defect as uterine fibroid or adhesions. Trauma, criminal interference, endocrinal disorder as hypothyroidism, diabetes mellitus. Pathology of abortion. First 8 weeks gestation, separation of decidua bacillis and expulsion of the ovum if retained within the uterus. The ovum becomes surrounded by decidua and blood clot. 12 weeks of gestation, rupture of decidua capsularis and expulsion of the product of conception. After 12 weeks, rupture of membranes followed expulsion of the product of fetus and the placenta retained in uterus. Types of abortion. Spontaneous abortion, threatened abortion, missed abortion, inevitable abortion, complete abortion. Incomplete abortion, habitual abortion, therapeutic abortion, criminal abortion, septic abortion. Signs and symptoms of abortion. Threatened abortion. Cervical loss is closed. Membranes are intact. Pain and backache may or may not be present. Treatment. Complete bed rest, avoid enema and constipation, no sexual intercourse, administration of prescribed drug. Incomplete abortion. Severe bleeding. Cervical loss partly closed. No uterine involution. Pain may or may not be present. Uterus is soft and smaller than the expected period of pregnancy. Septic abortion. Tender and painful uterus. Offensive vaginal bleeding. High temperature. Rapid pulse. Unstable blood pressure. Shock. Treatment. Isolation. Clinical bacteriological to identify the infectious organisms. Administration of antibiotics as doctor orders. Intake and output chart should be kept. The soiled pads should be properly collected and burned. Inevitable abortion. Bleeding is excessive, more than 10 days. Blood is red in color with clots. Severe colicky, lower abdominal pain. Cervical loss is dilated and rupture of membranes has occurred. There is severe blood loss and the woman becomes shocked. Treatment. Hospitalization if no heartbeats are detected. A dilute solution of oxytocin may be given as the doctor orders to help in the expulsion of the contents of the uterus. Dilatation and curage should be done. Missed abortion. Some signs of pregnancy disappear. Pregnancy test will be negative. Fundal height does not increase in size. The breasts may secrete milk due to hormonal changes. FHR are absent. No fetal movement. A sonar test confirms fetal death. Some brownish vaginal discharge. Complication of missed abortion. 1. Hypofibrinogenemia. 2. Infection leads to septic abortion, septicemia, septic shock and death. Habitual abortion may be due to cervical incompetence, poor nutritional status, hormonal disturbance, defective ova or spermatozoa, Rh incompatibility, chronic nephritis, treatment of the cause such as cervical incompetence or treatment of causative diseases as syphilis, DM, etc. Complete abortion, there is minimal bleeding. Pain stops. Uterus is hard and much smaller, the cervix is closed. Nursing management of abortion, prevention measures should be taken to avoid risk of a spontaneous abortion. A nutritional diet. Avoiding smoking or drinking. Receiving available immunizations against infectious diseases. Treatment of vaginal or pelvic infections. Hydatidiform mole, vesicular mole. Hydatidiform mole is a gross malformation of the trophoblast in which the chorionic villi proliferate and become avascular. Causes. The exact cause is unknown. Risk factors are maternal age above 40 years or below 19 years. Malnutrition types 1 partial mole 2 complete mole. Signs and symptoms: excessive frequent vomiting, overdistension of the uterus and larger than expected for weeks of gestation. Some vaginal bleeding may occur plus vesicles. No fetal movements, no fetal parts. Positive pregnancy test result in highly diluted urine 1 to 500. Complications: hemorrhage, shock, perforation, uterine sepsis, choriocarcinoma. Management: admit the woman into hospital. Evacuation of the uterus under general anesthesia. Health education on the following: need for monitoring HCG levels for 2 years, monthly for the first 3 months, then every 3 months for 1 year. Birth spacing methods to prevent pregnancy for 2 years. If HCG levels remain more than 5 international units per liter 8 weeks postpartum, prophylactic chemotherapy is indicated. Ectopic pregnancy. Pregnancy occurring outside the normal uterine cavity. Ectopic pregnancy usually occurs 99% of cases in the uterine tube. Tubal pregnancy causes impaired tubal ciliary reaction, impaired tubal contractility, decreased sperm mobility, the use of intrauterine contraceptive device. Risk factors: pelvic inflammatory disease, history of previous pelvic operations such as D&C, ovarian surgery. Signs and symptoms: short periods of amenorrhea, sudden, recurrent, colicky, abdominal pain in one iliac fossa or entire lower abdomen, blood-stained vaginal discharge, signs of shock, dyspareunia. Possible outcomes of tubal pregnancy: tubal abortion, tubal mole, tubal rupture. Management: evacuated immediately. Salpinectomy is performed. Provide emotional support. Follow-up is needed. Family planning should be discussed. Bleeding in late pregnancy. Antepartum hemorrhage is defined as bleeding from the genital tract between 28th week of pregnancy and onset of labor. Classification: placenta previa, abruptio, placenta extraplacental bleeding, cervical polyp. Placenta previa, placenta is partly or totally implanted over the lower uterine segment. NR5 causes: no specific cause can be detected for most of the cases, while the predisposing factors are large placenta previous uterine scarring multipara. Incidence: degrees: placenta previa lateralis, placenta previa marginalis, incomplete central, placenta previa, complete central plus. Incidence occurs in 5% of all pregnant. Degrees: placenta. Effects of placenta previa on pregnancy and labor: abnormal presentation and position, premature labor, prolonged labor, more chance of surgical intervention. Placenta may be adherent. Postpartum hemorrhage, fetal malformation, high incidence of fetal hypoxia and mortality, maternal shock, maternal death. Management in hospital: conservative treatment if bleeding is slight, observe carefully and correct anemia. Active treatment if bleeding is slight. The placenta is of the first or second degree. The fetus lies longitudinally. The patient is in labor, with good uterine contraction. Caesarean section is indicated if the patient has lost a large amount of blood. Placenta of 3rd and 4th degrees. Old primigravida or multipara. Posterior placenta previa. Role of the nurse. Bed rest and restriction of physical activity for at least 24 hours after admission. Avoid constipation, enemas, and vaginal and rectal examinations. Follow strict aseptic technique to avoid infection. Continuous observation of bleeding and signs of shock. Listening FHR every 4 hours. Accurate recording of intake and output. Abruptio placenta, accidental hemorrhage. Bleeding during the last 3 months of pregnancy. The first or second stage of labor, due to premature separation of a normally situated placenta. Causes. The most important cause is hypertension. The second most common cause is trauma deficiencies in vitamins C and K. Traction on a short umbilical cord. Sudden reduction of the size of the uterus. Types. Revealed, almost all the blood expelled through the cervix. Concealed, almost all the blood is retained inside the uterus. Combined, some blood is retained inside the uterus and some is expelled through the cervix. Complications. Shock. Acute renal failure. Postpartum hemorrhage. Consumption coagulopathy. Management. Treatment of toxemia. Replacement of blood loss. Treatment for shock. Obstetric treatment, in the presence of painful uterine contractions, artificial rupture of membranes. In the absence of labor pain, for syntocin drip. When labor pains are established, the treatment is continued as above. When the drip is a failure, a cesarean section must be done. Role of the nurse. Continuous observation of patient's general condition, blood pressure, vital signs, bleeding and signs of shock. Continuous observation of fetal condition. Initiation and continuous observation of for transfusion. Give medications accurately, especially for hypertension and shock if present. Regular urine analysis for proteinuria. Assessment and recording of intake and output. Assist in vaginal delivery, provide preoperative care, provide postoperative care.